This is a SICS by my trainee fellow. There is Rexis extension at 2 points and I took up the case. But while polishing the posterior capsule, PC rent occurred. Here it is. PC rent has occurred and now this simple case has become a complicated one. Now what to do? I'm thinking of converting this tear into a posterior capsular axis, but before coming out I inject viscoelastic substance. I find that the vitreous strand gets released from the tip of the Simcoe cannula and then I come out. Now I am trying to do posterior capsular axis. The axis has enlarged. I was trying to go from this side to the other side, but it came from the left side to the right side and it has enlarged. However, I was able to hold it here at around 7 o'clock and convert it into a posterior rhexis. Now I am implanting the intraocular lens. My idea is to place both the haptics at the equator of the capsular bag. The leading haptic has gone into the equator and now I am trying to place the trailing haptic into the capsular bag. Since there is vitreous strands there, it is becoming difficult to place these into the bag. However, at the fourth attempt here, I become successful to send the haptic into the capsular bag. And now, since there is PC rent, I don't want to take any risk. I want to suture this wound, and in this case I'm going to put a continuous shoelace suture. In this case the rhexis is extended at 2 points on at 6 o'clock. The other extension was at 1:30 o'clock. Let's see what I am doing. I am pulling the vitreous strands from the wound into the antechamber. Now I am taking one scissor and just blindly I am trying to cut the vitreous strands. This is not the ideal management, but till the vitrectomy cutter gets ready, I did this, and many of us have done this in the past. But we must use vitrectomy cutter. It doesn't matter whether you do phaco or SICS. If there is a PC rent, you must use vitrectomy cutter and manage the case very nicely. This is a SICS, and cutting the vitreous strands blindly with one scissor is not enough. Take it into your frontal cortex. We must use vitrectomy cutter and do anti-vitrectomy very nicely. There should not be any vitreous strands going to the wound. In this case I didn't use triamcinolone acetate, but one can use it to ensure that the vitrectomy has been done very well. And since there is PC rent, I am going to suture this wound. I am going to place continuous shoelace suture in this case. This is very good technique. When I was doing ECC long back, I have put continuous shoelace suture in many cases of extracapsular cataract extraction. And now I'm going to do vitrectomy. Vitrectomy cutter has been ready by this time. Here it is. The irrigation goes through the side port on the right side, and the cutter goes to the side port in the left side, and I start doing anterior vitrectomy and see what happens. The anterior chamber becomes so clear. All the particles come out. The vitreous strands get cut and they come out. The vitreous strands that was going into the wound has come back. So we must do anterior vitrectomy nicely. I followed up this case. This case was done yesterday. I followed up the case today, and the patient is doing very well. There is no vitreous strand going to the wound. There is no peaking of the pupil. The pupil is round, anterior chamber is quiet today. And all these have been possible because I have used vitrectomy cutter and have done vitrectomy very nicely. One can use triamcinolone acetate. The particles of triamcinolone acetate get entangled in the vitreous, and we can identify the vitreous strands very clearly if we use triamcinolone acetate. And since this is a steroid, the anterior chamber remains very quiet postoperatively. And now an air bubble has been injected into the anterior chamber. Now this is how we put the knot of the continuous shoelace suture. Pull the threads like this. Now two threads have to be separated from each other. One thread is cut short with Manual scissor. Now I take a loop of the longer thread and put this suture. This is the first, this is the second, and this is the third loop of the knot. Now as we cut the threads near the knot, see what happens. The knot gets buried in the groove. And now I don't like to cauterize the conjunctiva and try to pull by contracture of the tissue. Rather, I will put a releasable suture which will not destroy any cell. This is a very good technique. You just put a releasable suture, and there is another technique which you can put a subconjunctival injection and the conjunctiva will come forward, but cauterization is not required. Now in this case, wound hydration was not required. All the wounds are sealed very nicely. Thank you very much for watching. Hope this video will help you in managing PC rents in SICS very well.